During this period, we have a total biopsy of 535 renal biopsy, native biopsy 370, transplant 83, and implantation 82.
So who were the dates?
From the 1st November 2018 to October 13, 2019. And it includes about consultation biopsy we got that were around maybe 3 to 4%. Of the implantation biopsy, 7 have vascular disease of donor origin, 2 IgA and 2 thin basement membrane disease. Rest were pretty much, there were no abnormalities in rest of the implantation biopsy. Maybe some mild tubular injury, some pretty minimal chronic changes. We had 83 transplant biopsy during this period. These were the number of biopsy, not the number of patients. And we received biopsy as early as 7 days post-transplant to 29 years post-transplant. Age group of the patient was 60 to 79 years. And of that, of the 83, 26 we got a rejection. 25, there are no rejection, no specific change, some mild degree of chronic changes.
So biopsy the 29-year post-transplant.
Actually, there was rejection on that one.
Okay.
Chronic antibody rejection.
Oh, 29 years.
Wow.
And recurrent disease we found in 11 cases. Tuberculosis toxicity in 8 cases. Polio virus we found in 4 cases. As early as 4 months post-transplant, up to 5.5 years post-transplant. And 3 cases we had rejection and recurrent disease both. That included one of IgA, one of immune complex, and one of diabetic nephropathy. And one of thrombotic microangiopathy, and one biopsy was inadequate. Of the 29 rejection cases, where the rejection was as early as 5 weeks up to 29 years, and the age group of the patient was ranged from the 6 years to 79 years. Most of them were the chronic active TCMR, 10 acute TCMR was 9, combined antibody mediated 4, and chronic antibody mediated 4, and chronic active ABMR 2. Among the 14 recurrent diseases we have, almost half of them were IgA, 3 diabetic nephropathy, 2 lupus, 1 of FSCS and 1 membranous, and 1 immune complex GN query C3 because the diagnosis and the biopsy was done before 2010, this one, and we didn't have the C3 GN at the time as a diagnosis. Among the 370 native kidney biopsy, almost every 5th case we had was IgA. Diabetic nephropathy around 11%, FSCS 8%, lupus 7%, and these 4 diagnoses form almost half of the total diagnosis that we have. Rest of the diagnoses in a descending order were hypertensive nephrosclerosis, and around 6% of the time there was no specific diagnosis. Some of them were normal, pretty much normal, and some mild chronic changes were present in rest of the biopsies. Autoimmune, we have 20 cases, membranous 19, and diffuse glomerular sclerosis 13 cases where we could not find any primary disease. Chronic TIN 11 cases, C3 glomerular nephropathy 10 cases, 8 cases each of acute tubular injury and 3 basement membrane disease. Out of this, 1 we were able to diagnose as Albert syndrome. Acute interstitial nephritis 7, post-infectious 6 cases, and minimal change also 6, and 5 cases each of amyloidosis, anti-GBM antibody, and proliferative immune complex CN. Of these 5 proliferative immune complex CN, they were full house immune complex CN, but the ANA was negative, and so we couldn't make it as a case of lupus nephritis. We label it as it fitted mainly with the ANA negative lupus-like nephritis, which more or less have a same clinical picture or as a renal limited lupus. 4 cases each 4 cases of fibrillary GN, and 4 biopsy were inadequate to interpret. 3 cases of light chain, 2 cases of TMA and MPGN and prior. 1 cases of chronic CIN toxicity we found in a native kidney biopsy. The patient was a liver transplant recipient. And 1 cases each of C1q nephropathy, monoclonal IgA, renal infraction, and on a single occasion we received intermodal. So going on the individual disease, the total number of IgA we had were 85, of which 77 were native, 6 transplant, 2 donor. And when I reviewed the urinary findings, 6 patients had proteinuria only throughout their disease course that we had on the native care. And 8 patients had hematuria, and rest had both hematuria and proteinuria. Going with the histomorphology, more than half of the patients have mesangial hypercellularitis, segmental sclerosis, and moderate to severe chronic cortical changes. 35% of the time we found endocellular hypercellularity, and 22% of the time we found active present, but it was not good enough to categorize as none of these cases were good enough to categorize as RBGN. The maximum number of present we found active were around 35% in IgA. Of the FSGS, only 1 was from the transplant, and most of them were non-specified. 7 perihilar, 4 cases of deep FSGS we found, and 2 collapsing, out of which 1 was HIV positive and 1 was HIV negative. Among the diabetic nephropathy, there were 45 cases in total. Most of them were, the 21 cases were in the class 3, 4 were in the 15 were in the class 4, and 7 were in the class 2B, and 2 were class 2A. Lupus nephritis, we had 30 cases, out of which 28 were native, 2 were transplant, and half of them were diagnosed in class 4, followed by class 3 number 5, and then class 5, 3. We have 2 cases each of class 1, class 2, and combined class 4 and class 5, and 1 of class 3 and class 5. The maximum NIH activity index we found was 14 out of possible 24, and the chronicity index was maximum we found was 10 out of the possible 12. And 1 cases out of this we had was incidence of renal cell carcinoma we found in around January, and the patient died actually 1 month post biopsy. That was in January. TMA, we had 3 cases, 2 native, 1 transplant, and 1 severe acute leading into the infraction of the kidney, and 2 chronic cases. The transplant one has chronic TMA. 11 cases of chronic tubulointerstitial nephritis, where we found non-necrotizing granulomatous lesion in 2 of the cases. Post-infectious, there were 6 cases, out of which 2 were C3 dominant, 1 was IgA dominant. This IgA dominant was in a patient of the Staph aureus positive diabetic patient. 20 cases of autoimmune glomerulonephritis we found, out of which 13 were the PNK positive, 7 were the CNK positive, and 7 out of 20 patients presented with the RBGN.
Where's the clinical data for that coming from? Like, or just in general, is this interpretation of all the lab records from Netcare, or is this interpretation
Yes, from the lab
of that clinical information you're given for the
lab
biopsy?
record.
Oh, okay.
And we had 12 cases of RBGN during this period, out of which 7 were from the autoimmune. Anti-GBM, we have total of 5 cases, out of which 3 presented as RBGN, 1 fibrillary GN, and 1 lupus nephritis. So these were the data we had, the numbers that we have on the renal biopsy during this year. Thank you.
Thank you.
Right on,
Yeah,
thanks.
thanks.
So any questions?
Does that seem like a normal distribution of things? From being here for 3 months?
Diagnoses were missing.
Probably accurate. I mean, the IGA had a lot of like mild presentations, but I imagine that those were post-transplant or donor biopsies, because I don't know anybody who's biopsying isolated hematuria thinking that it's IGA other than in that setting.
Yeah, maybe don't
But,
assessment.
yeah.
Do you find, you might not have looked at this, I bet you didn't look at this, but is there a big big change in distribution between specific diseases in different hospitals? And the reason I ask is I have an impression that when I was doing the biopsies for the community hospitals in the Alex, I was seeing a lot of diabetic nephropathy, probably for a bunch of reasons you could speculate about, you know, but I was seeing buckets of people with nothing but class 3 diabetic nephropathy. But I suspect here you don't biopsy those people as much. But I was wondering.
Actually, I didn't have a chance to go through the individual hospital.
Yeah, it seems to just.
What would be the reasons why, or hypothesized reasons why they would and we wouldn't? I would think our practices would be similar, that atypical presentations, you would end up biopsying and sometimes it would still yield diabetic nephropathy unless they would have more atypical presentations of diabetic nephropathy there.
Well, I think there may be two things. I have spoken to nephrologists here who shall remain nameless, who are evangelists for not biopsying suspected diabetics.
Right.
Because if there's diabetes there, it's, I am told that
Right.
it is likely going to be a thing that crashes the kidney, even if there is a second disease
Right.
process. I'm not sure if that approach is taken in some of the other places. And the other one is we go to some place like the Alex, I think. There is an astonishing amount of pathology that you see in their biopsies, and it's sometimes somebody who's never seen a doctor for years.
Yeah,
and they're
so I was
sleeping
thinking
in
their
a-
population might be more interesting.
Yeah,
Yeah.
they're very interesting, but they're very unfortunate. You know.
Yeah.
I think a lot of those, they just don't know what the heck they're dealing with, you know, when they're coming in.
I see, yeah.
I haven't seen a doctor in 20 years.
Right, right.
Yeah, that's the diabetic
Is there not a higher need population in some hospitals as well? Is that potentially a?
I don't know
I
the
do
city
get a
well enough,
sense
but
that
there probably
there's
is.
Yeah.
more than average.
Yeah.
The Alex.
Yeah.
for sure.
The one that died of cancer, or did they die of the cancer, or did they die of something else?
I don't know, I mean, like, just take the record, it was like a 1 month post,
After the biopsy?
Yeah.
I remember that.
so the patient didn't have the, I think, I checked the records and 1 year before the biopsy, the patient, there was no carcinoma in that patient. And after the biopsy, the ultrasound report was available after 1 week of the biopsy, where there was 2 centimeter mass found in the kidney. And the patient died after 3 weeks of the ultrasound.
2 centimeter renal cell carcinoma usually isn't going to be that aggressive. Yeah, maybe, but of course, sometimes they have really ones.
And the vessel in that patient were pretty bad. There was necrotizing lesion in the arteries. So
How many times did the nephrologist meet the nephrologist come at 2 a.m. that day?
What was that?
How many times did you get called in at 2 a.m. by a nephrologist? only Alan. I guess I'm astonished in how few inadequate biopsies there are. Yeah, that's, you have what, 90 kidney transplant and then 370 native?
we had 83 transplant biopsy and 1 was inadequate.
Right, and then from the 370 native ones, only 4 or 5?
4, yeah.
That's pretty remarkable.
Yeah.
Kudos to our
Did-
colleagues in Riyadh. Yeah, that surprises me. Yeah, I would have thought it would be adequate.
But doesn't adequacy depend on what you're looking for? Like
Yeah.
adequate enough that you could establish some sort of diagnosis, but not necessarily adequate enough that you could rule out other diagnoses, right?
Yeah, how
You
did
can
you
have one with
define
molecular
adequacy?
variables, but it's not
Adequacy,
deletion.
the first
Right,
one is
then you're
if you
fine.
can find any disease process in the biopsy, even one glomeruli, if we see, there is like that is adequate.
Oh, I see, so you don't have a.
Some of the biopsy.
Well, it is a
It's
number.
a number.
Yeah.
Is that what you're,
No,
what
no,
you're
I know,
stuck
but
to
the way he
for
defined it is.
adequacy?
there's a
Adequacy, I mean like
diagnosis.
we're not able to give a proper report in that one. And some of the report were based on the IF and the EM finding also, but the biopsy were inadequate in the light microscopy. But we are able to interpret the patient biopsy in total, so otherwise the number would have gone high, just in the light microscopy.
Yeah, because in my, to my feel, it's more like 1 out of 10 to 20, somewhere in that range, more like indeed 5 to 10% where there is an issue.
Yeah.
It's very irregular, so I agree with you, it's remarkably low.
Do you guys not make a call on lupus nephritis if you have a full house immunofluorescence with like a diffuse or focal proliferative disease? Because you called it immune complex proliferative GN, but then you said most of these were full house, or some of them were, but you didn't call them that because they were ANA negative. Do you use the ANA criteria when you report back to us? If we said query lupus nephritis, you see a full house, I think
No, at the
I
time-
normally see,
at
you
the
tell me
time
it's
we
class
don't.
4 lupus.
No, I've never encountered.
No. When the clinician has made the call of lupus, we didn't do that. But when there was no call of lupus, and after discussion with the clinician and they don't suspect lupus, at that
I
time,
see.
at that time we made a call. of
Then you'll
lupus.
report as full house proliferative, but then it's up to us to make that call. I get it.
Oh,
Yeah.
Okay.
First, to paraphrase, the diagnosis of SLE depends on clinical criteria.
Of SLE, yes, but I mean, we would diagnose lupus nephritis from a full house immunofluorescence in a patient with no other explanation for that, and a negative ANA and no systemic symptoms of lupus. But,
Good to know.
I would never do that without talking to you.
right, I get it.
That's
Yeah.
a lupoid nephritis.
I think there are a few cases has been described as lupus-like nephritis
Yeah.
and a negative, and I think the recent change in the lupus criteria make it more difficult, where ANA is a mandatory to diagnose lupus.
Mhm. For SLE, yeah.
What's your rate of significant complications after hypertension?
Significant complications?
Yeah, I mean, I know that's not a great line distinction, but, you know,
So what was the question, sorry?
the complication rate after biopsy. Because it's something we never see, but, you know.
Oh, it's
these-
super high,
It's high.
Super high, but it's rarely severe.
Yeah,
But the number
okay.
of people that bleed to a certain
Yeah.
extent, it's about 5% or
A
something.
hematoma is common.
It's quite common.
Someone did an audit on this a couple of years ago, I don't remember the numbers, but it's high enough that when I quote like what I would normally quote for risks, I tell the patients, but honestly, we see these complications not infrequently, so.
How often do you have to transfuse?
It's usually 1 in 50,
One in 50.
generally.
But there is also conjunctivitis clots
Yeah.
and clots.
Maybe your radiologist is taking too much.
There's a lot of jabbing.
Yeah.
No, they just blindly poke, right? So, but I just do the same. I tell people that it is not unlikely that they will get a bleed because it's so common. Not a bad bleed. What I still find difficult is if you think about the numbers of people, the mortality of a biopsy, then, so I had a 27-year-old with nephrotic syndrome sitting in front of me this morning. And yeah, the numbers are 1 in 10,000 to 25,000, but that includes people that are being biopsied in ICUs and are almost dead and whatever, right? So, but how do you realistically inform the people that just walk into your clinic with an acute nephrotic syndrome? I'm not entirely sure, except for saying that the chances are low. But,
So can I throw out some idea about the previous case? If you think that IgG was IgG4 and that was a reason the serum was